Thank you very much. It's a real pleasure to have a chance to talk to you. And I struggled a bit to know what to talk about, but you can see the title, and whether you think the talk has any relevance to the title, you can judge at the end. But I will explain about the P's and the R's as we go along. So just a few preliminary comments. First being, I need my glasses to read this. So I know you're not all medical statisticians, but I am, and I'm going to focus primarily on medical statistics. However, I think the broad principles of what I say do apply way beyond medicine, and also medical research affects all of us because we are all current or future patients, and so we mustn't forget that. I'm going to outline a lot of serious concerns with published research. A point I'll make more than once is that a lot of that research, in medicine at least, is not done by statisticians. I don't wish to imply that statisticians don't make mistakes, but I think there's a particular climate in medicine where a lot of the research is not done by statisticians or methodologists. And just to emphasize a point, which it should be implicit, all the examples I give and all the reviews that I might allude to are based on peer-reviewed research. This is research that's supposed to have gone through quality filters. Well, indeed, it has gone through quality filters, but it clearly has survived unscathed. 20 years ago, almost exactly 20 years ago, I was writing this editorial. It appeared in January 1994. It was called The Scandal of Poor Medical Research. And so to some extent, I shall consider how things might have moved on in the 20 years since I wrote that. Within that editorial, I said, what should we think about researchers who use the wrong techniques, either willfully or in ignorance, use the right techniques wrongly, misinterpret their results, report their results selectively, cite the literature selectively, and draw unjustified conclusions? We should be appalled. I then go on to say these things are all very common, and this is surely a scandal. And it shows the advantage of using quite a strong term, because people clearly noticed that editorial, and I'm planning to update it. Okay, so what we want in medicine is reliable evidence. Clinical practice and public health policy decisions rely on reliable evidence, high quality information about clinical research. I'm not only thinking of randomized trials. Quite a lot of the studies I will refer to are randomized trials, but this applies more widely. That clinical research is only going to have value if the study methods are valid and that the findings are published in a usable form. So we need reliable evidence from research, we need good quality research, and we need good reporting of that research. And I'll come back to that towards the end. And it's clear, I hope, well, it is clear to me, and it will be to you, that we don't get this. We don't always get good quality research, and we certainly don't get good reporting. It should be obvious to statisticians that these are the ways we go, that the study question is where it all starts, and that should be precisely identified. The study design should be targeted to match that research question. The analysis should be targeted to match the design, and then you should interpret the results appropriately, and it doesn't, and then the findings should be published fully and accurately and not in a misleading way. And it's obvious as well that people like us have a valuable role to play at every stage. And one of the huge changes I have seen over 20 and indeed 30 and more years is that nowadays it's absolutely standard to be asked to give advice right at the very beginning, and it just never happened at all when I started out as a statistician. I can't remember. I'd been working for many years before I was ever asked to help design a study. So, statistics is great. We all like that. But as I said, a lot of statistical analyses in medicine, at least, are done by non-statisticians who have access to very fancy software, even doing analyses I don't understand. But that's all right, because it's a computer, and we trust what we get. So how might research lead to harm? I'm talking you know, if statistics is not good for you, if it's bad for you in some sense, and I use the word statistics in an extremely broad sense to encompass the whole of study conduct, really, it might be harmful if the results are misleading, and that could be because the methods are wrong, the design is incorrect, or the analysis is inappropriate. It could be harmful because the study simply is not published, which is somewhat outside what I'm talking about today, or I will touch on it again. Or more likely, that the publication itself is in some way misleading. It could be misleading in that the methods are described incompletely or indeed incorrectly, that the findings are published only selectively, or that the findings are misinterpreted. And of course, you have the wonderful situation that you can have all of these things in the same paper. And these are some of the common problems which I'm sure you're familiar with. And this sort of repeats some of what I said. The design could be wrong, the sample could be unrepresentative, the study size could be too small to yield any sort of reliable answers, the analysis could be wrong. You could have multiple analyses and selective reporting. I think, I'll say it now in case I forget later, that could well be the most serious problem with the literature, because all studies have multiple analyses. Interpretation can be just crazy. The errors that people make are often very simple. I'm not going to have time to give many examples of that, but you know, really basic things. I'm looking at papers where the confidence interval doesn't include the point estimate. How does that get into print? But it does happen. But the impact of errors, not that one particularly, but the impact of errors, of course, can be highly serious. So, I mentioned P's and R's in my somewhat inscrutable subtitle. The problems, which are the P's, are p-values, publication practices, and something I'm not going to talk about, but personal and vested interests. And often these three things go together. So people with a particular interest, which may or may not be commercial, carry out certain bad publication practices largely related to what the p-value was. So these three things go together. And then I'm not going to say I have the remedies for these, but there are at least some partial remedies to try to make things a bit better. Replication of research, reporting transparently. Let's see the raw data. Let's have reproducible research and research done for the right reasons, and that phrase you may have spotted earlier. And let's have more responsibility for what people are actually doing. And interesting, a link between these perhaps is peer review, which is a P and an R. Quite pleased with that. Okay, some years ago, 1984, so now we're going back 20 years, a little book appeared, Problems with P. And every chapter of this little leaflet, which I managed to find in my collection, every chapter begins with the letter P. And it was, I guess, perhaps a subconscious inspiration for the way I've approached some of this presentation. The main concerns with p-values are that they influence which studies get published, they influence which results get published, and that is highlighted because, as I say, I think that's really crucial. So-called significance chasing, whereby people only want to publish significant results. The belief that p actually means something useful, misinterpretation of p-values, and something I will talk about, the idea that you can compare p-values to do a meaningful analysis. And I'll give some examples. I'm going to cite this guy a few times. This is John Baylor, who said a lot of really quotable things. And one of the things he said is, science is not a game with points for the most significant p-values. And I will return to John at a later point. It's not the only one who draw analogies with sport or games. Here's another quote. Evaluating research by a single number is embarrassing reductionism, as if we were talking about figure skating rather than science. Now this, Alan Wilcox was talking about the impact factor, but he could have been talking about the p-value. It would be a similar view, and you might argue that this applies more widely. I personally think a correlation coefficient on its own is equally useless as a summary of a data set. So let me give you a case study. This is a paper from the most highly prestigious medical journal, the New England Journal of Medicine. Being highly prestigious does not make it immune to the problems I'm talking about. Why that is an interesting question. So here's a trial of vasopressin versus epinephrine for out-of-hospital resuscitation, people who've had a seizure out in the community. And the ambulance is called and it comes and they administer one of these treatments. And interesting primary outcome here is reaching hospital alive. And I think most people would think that leaving hospital alive would be a more useful outcome. As it happens, rather sadly, most of these patients don't leave hospital alive. But what I'm going to say, the results are actually quite similar, whether you look at either outcome, but this was their nominated primary outcome. The overall odds ratio, the overall result is here. As you see, you'll see in a minute which way around it is, but the odds ratio is 0.8. The p-value is not quite statistically significant using standard criteria. This is the result. These are the actual numbers, the event rate, the events proportions, 36%, 31%. That's the odds ratio. And of course, that was rather disappointing. So they split the patients into 3 clinical subgroups shown in blue. And those are the results. And you can see the p-values are there. And I don't really need to highlight the point that one of them is significant and 2 of them are not. And that is the result which they rather liked. Now, I would argue, I hope you would agree, that comparing p-values is not the way we should do statistics. In fact, we can't do exactly what we need from these data, but approximately we can construct an interaction test, and it's nowhere near to being statistically significant, which I don't think will surprise people. But that didn't stop them drawing a lot of conclusions about this. The overall finding doesn't appear in the abstract, for example. In fact, it's not mentioned in the results section either, which is somewhat bizarre. So as I say, the overall result for the primary outcome is only shown in a table. The focus of this paper is entirely on this subgroup analysis, and in particular, this significant effect in one of the 3 subgroups. There's nothing in the method section about even doing subgroup analyses, and as I said, there's no significant difference if you do a correct analysis. Now, this type of analysis where people do within-group analyses and then compare the results by contrasting p-values is extremely common. That doesn't make it right. It's one of many things that are extremely common and are wrong. 2 tests are not better than 1. So that what you often see, slightly differently but comparable, you see paired tests against baseline values for each treatment group where you have a trial with a continuous outcome. And that's very common. And then what people say is, well, if it's significant in one of the treatment groups and it's not significant in the other, then the treatment works. You know, that one treatment's better than the other. Well, I can understand why people think that way, but this is conceptually wrong, and I think it's statistically invalid, and it's therefore highly misleading. And Martin Bland and I published a study where we actually did simulation studies to look at this practice, and we found that the type 1 error rate of this procedure can be as high as 50%. And I think you would agree that that is totally unacceptable. Even if we thought this was a meaningful thing to do, which I don't, the type 1 error rate makes it completely unacceptable. And in fact, relevant to the study I just shown you, when there are 3 groups, the type 1 error rate can go even higher than 50%. So where you have a small or 0 effect, the chances of getting a significant effect in one group and not in the other can be very high. And this applies to subgroup analyses, as in the example I had, or in the baseline comparison which I just mentioned. This is, just briefly, this is a review of studies in neuroscience looking at studies where they felt that there was, what they say is authors might be tempted to make an error of the type I've just described. And they basically found, I mean, they expressed it in a positive way. In 50% of these cases, the authors used the correct approach. Great, that's great. But the corollary of that clearly is that in 50% of the cases, they used the wrong approach. And that's, you know, that's really bad. So we've got a large prevalence of incorrect methods with a high type 1 error. That obviously is part of this. People like these methods because they yield significant results, but they're not valid. Let me give you another completely different example, but again related to just not thinking about p-values and not thinking straight, if you like. This is not randomized trial. So this is liver transplantation, and the question, although it mentions hepatitis C, that isn't really the key point that I wish to make. The question is whether the age of the donor affects the prognosis for the recipient. Get that right. So the donor is the person whose liver is being removed, and the recipient is the one who's receiving it. Obviously, the age of the recipient may be relevant, but we're just looking at the age of the donor. And in particular, the first source, what they do is they define older donors as over 60. So they dichotomize, which is a stupid thing to do, but that's another thing that's totally prevalent, widespread in the medical literature. If you see a continuous variable, dichotomize it, and if possible, do it in the most stupid way you can. So this is the abstract of the paper. No difference was demonstrated. Now, I hope many of you are like me. When you see the word no difference, you think, not sure about that. No difference was demonstrated in short or medium-term patient or graft survivor in recipients of grafts from older donors. And then they go on to say, well, this suggests that we can, because basically they don't tend to use livers from older patients because they're concerned about the prognosis. But there's a shortage of livers for transplantation, so if they can stretch the limits, that would be a good thing. But only, of course, if it's a safe thing to do. So that's what this study is getting at. But if you look inside the paper, you see that the hazard ratio was 3, and the confidence interval goes from 0.7 to 12. There were only not very many patients aged more than 60. I think it was 24. And so we're talking about single figures in terms of numbers of people who actually had a failure, either they died or they had a rejection. So these are tiny numbers. And as somebody else pointed out, there are 25 other studies out there saying that older donors are associated with worse outcomes. So they've interpreted a non-significant result on a small sample, an underpowered study, using an inappropriate cut point as evidence for a change in clinical practice which really could affect people. And they've simultaneously ignored a large body of existing literature which they absolutely should have taken into account. And this is published in one of the top surgical journals. Something should have happened then. Right, so this is Reuters. Liver transplants from elderly donors are safe. Now, that's even worse, of course, than what the journal article said, but this is from a press release. So press releases are a malign thing that go on under the surface. Here's another one. It's remarkably similar. That's because they basically take the press release and they publish it. But the next one is a gem. This is biomedicine, and I'll highlight the really important bit is this. They misunderstand it. They say patients who undergo liver transplantation at age 60 have 1 year and 5 year survival rates similar to those of younger patients. That's not what the study says at all. Nothing to do with the age of the recipient. And they don't mention the fact that it was only looking at hepatitis C positive patients, which is minor detail. So that's the sort of thing we see. And I mean, of course, these are carefully selected, and I can't tell you how common that sort of thing is. But that type of misinterpretation of non-significant p-values, you'll see that in any issue of any journal, I think. Here's something else. This is a randomized trial. Juggle my thing. This is a randomized trial of prostate cancer screening, 31,000 invited men, 15,000 not invited. A fantastic result, a relative risk of 0.38. However, what they've done is compare the screened men amongst those invited with the unscreened men amongst those not invited. And as you see, there are 7,000 men here and 14,000 here, because most of the invited men didn't go for screening. So these are self-selected, and it's well known that people who self-select are not random. And if you do an intention to treat analysis, you actually get a relative risk that's more than 1. That's taking all of these patients together, and at least they present the data to enable you to do that. But if you don't know how to interpret results, it's very easy to buy the author's explanation. I need to speed up. So I want to say something about selective publication. I've already talked about it. This is something which was barely discussed 20 years ago. There was a lot of discussion about non-publication, studies that never got published. But selective publication, there wasn't really much out there. So here's an example, before I get on to that, about non-publication. This is about cancer trials, phase 3 cancer trials. You'd think they were quite important, but it says here, a substantial number of cancer clinical trials with potential influence on clinical practice remain unpublished. And it says, breaks an implicit contract with participants, institutional review boards, and sponsors. But also, we know that the unpublished studies tend to have much less evidence of benefit, shall we say. They tend to show little or no benefit and non-significant results, and people don't bother to publish them. That means that when you do a meta-analysis, you have a biased set of all the trials that have been done. And that has been known for quite a long time. What you do about it is another matter. This is a particularly interesting example of trials of antidepressants comparing published and unpublished. And this is based on data sent to the FDA. So we know the total amount of data. Of the 40 of the 40 published studies, 37 had statistically significant or positive results. But of the unpublished studies, there was only 1 significant result there. Or put another way, of the non-significant results, only 3 were published, and all of these, 14 I think, were not, and all but 1 of the significant results was published. And so the total evidence base depends on where you look. If you look in journals, you get totally the wrong answer, and you think that these drugs are much more effective than they are. And there are similar issues with safety. But let me come to the issue of selective reporting. This is a recent update of a review published a few years ago looking at, it's a review of reviews basically, a review of studies that have compared trial protocols with trial publications or trial registries with trial publications. And without going into numerical detail, the summary is there's strong evidence of association between significant results and publications. Studies that report positive or significant results are more likely to be published, that's what we've just seen, but outcomes that are statistically significant have higher odds of being fully reported. That's what has come up in the last 10 years, that it may be a surprise to even people working in trials find it surprising that the median number of outcomes in a clinical trial protocol is around 30. They certainly, the median number being published is nowhere near 30, and so there's a lot of scope for selective analyses and reporting, and that isn't allowing for the fact that there are often many different ways of analyzing the same outcome. So you can certainly play around for a long time and get something significant if you try hard enough. And this is what we see consistently. We see an inconsistency between publications and protocols across many contexts. So that's obviously a bad thing. We found in one of our studies that the primary outcome in the publication differed from what it said in the protocol 60% of the time. So these are not small problems, they're huge problems. If you move to other areas, talking about selective publication, this is in the field of biomarkers in cancer, a study of, I think, approaching 2,000 publications. Only 3% were resolutely non-significant amongst those 2,000 or so articles. This is a funnel plot from a meta-analysis of C-reactive protein in coronary artery disease. If there's no, basically, this is the meta-analytic result here. And the point should be symmetric around that. And this is one of the most asymmetric funnel plots I've ever seen. And all the ones in the gray are the statistically significant results. Now, there are some over here, but that is not consistent with unbiased publication practices. And it's one of the reasons why John Ioannidis, in this famous paper, which you may or may not have seen, argued that most published research findings are false. He was saying that most research is done in situations where actually the prior expectation of a true effect is quite low. And in that circumstance, plus all the selective publication, most of what you're going to see as apparent is illusory, and it will go away on replication. So let me come back to this. It says here we need less research, better research, and research done for the right reasons. And of course, I still think that. Do we have less research? No. It's easier than ever to publish. There are so many online journals, 10,000 online journals. New journals start weekly, and there's a weak joke there. And the number of journals out there doubles every 20 years or so. You can believe me, because I found it on the internet. No, it's actually, there's some quite good evidence of this going back to about the 18th century. It's just remarkable. But of course, the number of people doing research is going up as well, and that's part of the problem, because most of these people shouldn't go near research. This is this bit, research done for the right reasons. I wrote in that piece that much poor research arises because researchers feel compelled for career reasons to carry out research that they're ill-equipped to perform, and nobody stops them. And what I perhaps should have said is a lot of these people aren't even researchers. They're clinicians, nurses, other people who are compelled for career reasons to get publications. It's a condition of career advancement. And I would say that I'd like these people to have a chance to get involved in a systematic review. I think that would be really educational, but to try to do some poor quality research on their own and publish it teaches a lot of bad lessons, not good lessons. And I found this, basically, unless the system of rewards is changed, the avalanche of publications won't stop. And if we're concerned about the quality of research evidence, it would be far better, wouldn't it, to have less of it and a higher standard. And what's happening is, it's just not, it's like a runaway train, really. So this is something I found which might amuse you. This is Mount Purgatory of medical research. The first step is to improve your CV, derive satisfaction, increase knowledge, change behavior, and finally, improve health. So, but the purpose of medical research is this. It's not this, for sure. And what we hope is that we can do this whilst we do that. But unfortunately, I think much research is stuck down here in the foothills. Peer review. I could give a whole talk about that, so I'm not going to. But I'm going to just say this. It's part of the problem, but also potentially part of the solution. But it is clearly, as the number of journals goes up, the total amount of peer review that needs to be done goes up, and it's unmanageable. And I don't actually have a particularly clear view on how we go on that. Some people think we should just abandon it, publish everything, and have post-publication peer review via people sending in comments. And that works in other fields. I'm not convinced it would work in medicine. And I think arguably, certainly for some types of medical research, it might be okay, but for clinical trials, I wouldn't be very pleased about that. Clearly, peer reviewers are failing to detect important errors in design, in analysis, and omissions in reporting. But there is no training for peer reviewers. Virtually nobody is told what to look for. Even the journals don't tell the reviewers what they want. And I think we could do a much better job there. Having said that, I think there is so much of it. I'm really not sure what the answer to that is. The consequences of bad research are made worse if you don't actually know exactly what people have done. So I've spent a lot of time over the last 15 or more years pushing the idea that we need much better reporting of research. At least let us know exactly what people did. We can then see, if we have the right training, we can see what, that it's a flawed study. And clearly the examples I've given, I can show you the flaws because they've reported at least reasonably well what they did. But assessing the reliability of research via published articles is hugely impeded if you don't have good reporting. And there are big, serious consequences, which I've got up here, which I won't go into. So the consort statement, for example, which is a reporting guideline for randomized trials, and that has basically a checklist and a flow diagram, has been quite well taken up. Hundreds of medical journals ask their authors to follow this, but the adherence has improved modestly, to be kind, even though the endorsement is quite strong. So there's a real problem of implementation here. And if you're not familiar with it, I'll plug our Equator Network website, which has information of over 200 reporting guidelines, and we've just revised it. I'm very proud of it. This is only this week we have this new website. Well, it's the same website, but I mean, it's just different. It looks better. So I won't go into that, but this is where you can find all sorts of things about reporting research. Another R, registration. Clinical trials, it's mandatory now to register trials. That isn't being done particularly well, but it's being done reasonably well. And it gives you a baseline against which many journals now go to the register when they receive a report of a trial. They compare what they're being told with what the authors said they would do, and they expect to see an explanation of major differences. Other people are saying, well, why can't we do this in epidemiology? Why can't we do this in preclinical research? And the answer is, in principle, you can. In fact, on clinicaltrials.gov, there is a lot of observational studies. There's no restriction to clinical trials. I think it's good practice. And we're moving in that direction slowly. We're also moving towards what's called reproducible research. This is an editorial in Annals of Internal Medicine. Basically, we're moving towards the idea of primary investigators sharing their data, sharing their protocol, sharing the protocol, the data, and the computer code to make the whole thing fully reproducible. And it happens in a limited way, certainly in some statistical areas, very rare indeed in medical studies at the moment. Replication, very important. I like this title. If it's worth doing twice. And arguing that studies should be reproducible. And I say, in terms of reporting guidelines, if you're writing up a study, you should write it in such a way that someone else could repeat that study from the information in your article. And that should be the aspiration. You may have to refer to other documents to do that, but I think that's exactly right. A recent study of these researchers, they could only replicate key findings of 1 in 4 published preclinical cancer studies. That was published last year in Nature. It was rather concerning. This year, Nature has changed its policy, a very important change. They're no longer having any word length restriction on the methods section of research papers. I think that's a very significant change. I'd like to see other journals do that. Now that you can put stuff on the web, there's no reason to have word limits which prevent authors saying exactly what they did. Publication of protocols was mentioned there. I think it's a great idea. Some journals now require it, some even publish it as an appendix. This will increase. This is the direction of travel. Again, what about other types of research? We could do better. Oh, wrong button. And here are some examples from 4 different journals, or 3 journals, and yeah, anyway, there's lots of publications of protocols out there now, hundreds of them. We've recently seen people start to publish their analysis plans. And this idea of a thread of linked publications with the registration number in all of them, so you can find the protocol, the analysis plan, the results, and maybe even the raw data. I haven't time to say much about that, so I'll move on. But I do think it's great if we can publish raw data. And here's an example. This was published in Trials. The whole of the IST trial raw data are published as an Excel spreadsheet as an attachment to this paper. Again, I see positive direction of travel, but there are hundreds of thousands of papers published each year. Only a handful are going to reach this level, I think, in the near future. I'll skip that. Responsibility. I think authors don't take enough attention to their responsibility for what they do. When you submit a paper to a medical journal, you have to sign all sorts of ridiculous documents about conflict of interest, but you don't actually have to sign anything relating to the honesty and accuracy of the article. So, which seems to me, ridiculous. So we've just published something in the BMJ, just very recently, suggesting a transparency declaration that authors actually have to affirm that the manuscript is an honest, accurate, and transparent account of the study, that they haven't omitted important details, and if it's changed from what they plan to do, that they've explained why. And the BMJ has instituted this as a policy immediately. I'm sorry about that for those of you sending paper to them. So is statistics good for your health? Well, it should be, but clearly I think the misuse of statistics can harm people. And here's a quote which I won't read out, but this is not from me, from other people, saying that basically poorly reported findings have the potential to cause real harm. This is poor reporting, not poor conduct. John Baylor said there may be greater danger to the public welfare from statistical dishonesty, which I believe is another word for what I'm talking about, than from almost any other form of dishonesty. So I have some slides. How am I doing? I've got 5 minutes, good. Okay, so what should we do as statisticians? This sort of misuse of statistics, I think, reflects very badly on statistics as a profession. It's bad for science, it's bad for people, and it's bad for our profession. And we should, well, basically we can either just say, well, what can we do? It's out of our hands. And to some extent that's obviously true, but I think we ought to try to do what we can as individuals and also as a society. For a start, we should be aware of these issues. We should be aware, and as I say, I don't think this is just in medicine, but I know it is not just in medicine. We should be aware of that. What are the most common things that people do badly in terms of methods, in terms of reporting? We should read widely to get a better idea of what's really going on out there. Don't just read the Lancet, although that's, of course, not immune from publishing rubbish. It's an unacceptable situation, and we should not accept it. But real power to change things isn't in any one group's hands, and it's very frustrating. There seems an inexorable rise in demands on people to publish, and having the publications is more important than those publications actually being valuable and reliable. If you're a collaborator on a research project, try to be involved at the planning stage, try to ensure, obviously, that the study's done well and it's properly reported, ideally in a reproducible way. And one aspect of being reproducible is that the results could be included in a subsequent meta-analysis. A lot of meta-analyses have to exclude studies because although they know the study was done and it's been published, the results are not given in a usable format. Join research ethics committees and try and prevent people doing stupid things in the first place. Write letters to journals. Write articles. Especially when you see repeated mistakes being made at a very simple level in the same journal. Carry out anything that will raise the profile of this and try to shame people into doing better. And you can work with journals. Referee papers, of course, become a journal statistical advisor. I know some journals have many statistical advisors and many journals have none. But help to formulate policy and educate authors, editors, and readers. There's a lot that can be done. In terms of the society, I think I'd like to see the society making a more vocal statement about the misuse of statistics, which I think is, I think we should try to counter the impression that you can prove anything with statistics, and that it's, you can't trust statistics. It's important, I think, also to publicly support initiatives that aim to improve the reliability of research, such as the recent All Trials initiative, trying to make sure that all randomized trials, all clinical trials are published. And the 3 dots are because I'm sure other people can think of better things to add to that list. John Baylor, he said science is not a game with points for the most significant p-values. He's right, of course. This is Bill Shankly. He said, some people believe football is a matter of life and death. I can assure you it is much, much more important than that. And what I've done is to take half of each of those quotes to end with. Science is not a game. It is much, much more important than that. Thank you.
So thank you very much for that. We have some time for questions. Please wait till some of these wonderful people in pink t-shirts approach you with the microphone if you wish to ask some questions. So, Michael?
So you put up a slide about less than 1 in 4 cancer trials being reproducible, I believe. There was a trial you said...
They weren't, no, they were preclinical studies.
Trials, yeah. So my question, I think, is were the trials that were not reproducible for the reasons that you've given, namely the poor analysis?
Good question. Sorry, it was ambiguous. No, they were able to replicate the study but not reproduce the findings.
Yeah. But is that...
So in other words, the initial study had shown some promising results. It just did not stand up on replication.
But was the failure to replicate because the analysis that produced the findings was faulty?
Not as far as I know, but I mean...
That's a basic question, isn't it?
It is. No, I think the impression is more that this was a selected, carefully selected analysis, possibly with carefully selected data. Because another thing I haven't mentioned is the omission of certain data points that might be seen as inconvenient, which my spies in some medical areas tell me is quite standard practice, which is deeply worrying.
Fine.
So there's one here.
On top of all the other worries.
Chris Dent from Durham University and a mathematician who works as a lecturer in engineering. And just to comment that a lot of what you said rings true from my experience. But I think it's maybe a broader picture which he hinted at of people, for whatever reason, working outside the domain of their actual expertise. Because there's certainly plenty of bad attempts at techniques from mathematical sciences made by engineers, but there are also plenty of very bad attempts at engineering done by people from mathematical sciences who aren't familiar with that.
Yeah, I'm reminded of 2 comments from Michael Healy many years ago. One about his book on brain surgery, which would be so much more simple than a book that a surgeon would write. Michael Healy was a medical statistician, and he previously worked in agriculture, and he did pose the question, what's the difference between medical research and agricultural research? And the answer is medical research is done by doctors, and agricultural research is not done by farmers. It's a very deep comment for you to contemplate.
So there's one there.
You gave some very persuasive examples there, but I'm concerned about the remedies, that there's just more process, and we must all feel that we spend our lives doing more and more process and less of what we're good at and paid for. And I guess that caused me to ask the question, yes, but are these things actually harming medical practice? Does anyone really believe that the donor's age doesn't matter in a liver transplant, or does their natural skepticism protect them against that error? Do we need these processes, or can we just rely on people's skepticism as the defense?
I mean, you're right on all levels. Yeah, I mean, I think bureaucracy is a real problem. I'm not sure I have really good answers to any of these issues other than reducing the pressure to publish, because that's driving all of these things. In terms of skepticism, there is some quite good empirical evidence in some fields that people don't adopt poor quality recommendations, if you like. In the field of prognostic models, there are hundreds of thousands of these things published each year. Hardly any of them reach clinical use, and that's quite good, because most of them are really badly methodologically poor. But but whether that skepticism or inertia or something else, I don't know. But you're right, there are impediments to the uptake of clinical recommendations, but that paper in particular did make an explicit clinical recommendation which was unsound and unsafe.
So one final question from Sheila.
Sheila Bird, MRC Biostatistics Unit. Doug, I liked your remedy of new researchers taking part in meta-analysis, but I would add for all meta-analysts, experienced or newcomers, that they should not just summarize the evidence, but they should actually draft a protocol for how to do the next study better than the 10 or 12 or 20 they've read up until now, so that we really deliver tools for scientists.
Yes, I think I'd much rather see recommendations on how, what the next research should be than some not very well justified clinical recommendations. There's another problem we see at the moment with multiple meta-analyses of the same literature burgeoning and up to 10 or even more published meta-analyses of exactly the same body of literature, coming not always to the same conclusions. So there are many layers of complexity. But yeah, I think we should make people, the training should make people aware of the problems, and being involved in systematic reviews, which may or may not include a meta-analysis, would be a much better way of doing that. So, yes.
So I think we have to draw the discussion to a close. I think Doug has given us a lot of food for thought, and I think we should thank him again most warmly for his excellent presentation. Thank you.